Thank you for the opportunity to discuss transcatheter tricuspid valve replacement current status. These are my disclosures. One of the challenges which tricuspid therapy has faced, especially the repair technology, is the delicate valve structure and ill-defined annulus. One of the advantages of TTVR is it can eliminate tricuspid regurgitation. There's no risk of RVOT obstruction, and it doesn't necessarily depend on the annulus as well as leaflet structure. Further advantage being, because of the low closing pressures, the chance that any further displacement or residual PV leak is going to be less. There are 4 devices with first-in-man experience. Navigate was the first device used in tricuspid. This device has the largest experience at present, over 50 cases. The second device is a Lux device manufactured in China and has been used in China as well as Canada on compassionate ground. Intrepid mitral device manufactured by Medtronic has been implanted in tricuspid, as well as Evoke device again manufactured by Edwards has been used. There are 3 main approaches: superior vena cava approach, inferior vena cava approach, and transatrial approach. Each approach has got advantages and disadvantages, which we are going to discuss briefly later. Right atrial access can be planned very well with help of CT scan. As you can see, it limits the level of thoracotomy, as well as one can do a non-rib spreading thoracotomy. It gives you a direct access with a small purse string on the right atrium. One can not only position but position accurately by adjusting the device in all 4 directions, and then the procedure is also fast. The disadvantage, of course, being it's a surgical incision for delivery of the device. Transjugular access was initially used for navigate, but the challenge, of course, is matching the delivery system size to that of the jugular. The trajectory, as you can see here, this is the trajectory of the delivery system when in position. This is the tricuspid annulus, and if you need to pull the device or push the device, the tangent which you really need is perpendicular to the annulus, which can't be achieved at present through this axis. Secondly, the cath lab logistics become hard as you're working on the neck area with positioning of the C-arm. Transfemoral appears more promising as we have got a lot of experience now with transcatheter mitral interventions, and venous size is always larger. But one must still remember that although it looks in 2 dimension perfect, in 3 dimension the opening of the IVC and the tricuspid annulus are in 2 different planes. And this can of course make positioning challenging unless the delivery system allows double curve. So does actually TTVR make sense? One of the dangers, of course, is you eliminate the TR completely, the pop-off effect is going to go, and that may have deleterious effect on the RV function. Secondly, anatomically, most of the tricuspids we tend to see tend to be of large size. And if we tend to use the oversizing algorithm we have used in the mitral, it may actually have negative effect on the conduction tissue as well as the aortic valve. Further challenges being pacemaker lead presence, as we know that 1/3 of the tricuspid regurg present with some pacemaker lead in the right ventricle. Possibility of complete heart block after deployment, which may necessitate pacemaker insertion. Durability of the device, need for anticoagulation, and future valve-in-valve capability are also very critical in making this successful. You can see here these are the 2 cases, one with the Intrepid device on the left and with Lux valve on the right. You can see they have been done successfully with pacemaker leads. Pacemaker leads, of course, can interfere with the delivery of the device, seating and sealing of the device, as well as if the device fractures the lead, it can interfere with pacing as well. And all these 3 things should be kept in mind before. Looking at each individual devices in short, Navigate device, as I said, has the largest with largest experience. It's a shorter device which has a big advantage, and the second advantage being it's a very large device. The functioning valve can go as large as 50 millimeters. But the disadvantage, of course, is that if this valve degenerates, then valve-in-valve option is none at present. The delivery system is the first generation delivery system with 2 degrees of motion with 90-degree articulation. However, it's challenging sometimes to get the device in the right plane through jugular or venous approach. Evoke mitral device has now been used in tricuspid successfully. The biggest advantage being small caliber around 30 French with double articulation, but the disadvantage being unless you get the device in exact coaxial plane, it would not lead to a good positioning and capture. And the second, of course, is it's a non-recapturable device beyond a certain point. We still don't know interaction with pacemaker, what the effect could be. Intrepid device, on the other hand, again, large mitral experience and now experience through transatrial and femoral approach with dedicated delivery system. The advantage being it's a simplicity to deploy, recapturable device, but the disadvantage currently being large delivery system size. These are some quick steps to show you that visualization is mainly aided by fluoroscopy, but mainly done under explained under transesophageal echo, and hence getting good echo images is very critical. The steps are very simple as I mentioned before. Open the brim, position it on explain in all four directions, and then bring the valve down, and then deploy, and then return the capsule. CT scan has been pivotal in terms of planning, defining the tricuspid annulus in various phases. Look at the RV depth, what is the interaction of the device going to be with the moderator band. And as we go more in the experience, we're going to learn more in terms of exact sizing and oversizing needed. Mapping veins is critical, especially with devices with large caliber, something like 40 French. And you can see here that capturing it and mapping it has made us wiser to prevent any venous complication, which can be subtle but life-threatening. CT scan further gives you catheter vectoring, and again, getting tricuspid in the coaxial plane becomes important. This is more important when the right coronary artery is not in the annular plane or is blocked. And I think getting these right views to start makes the procedure shorter. These are two examples. One I've already shown you before in presence of pacemaker wire, the other being a patient with an incomplete tricuspid repair ring. And again, this is just to show you that the potential of using different devices in different anatomies is definitely possible. So what are my final thoughts? The positives of TTVR is it eliminates tricuspid regurg. It's applicable irrespective of the morphology, functional or non-functional. Future valve-in-valve is possible and replicate surgery. While the negatives are we still need better delivery systems, we need to understand pacemaker wire interaction, anticoagulation need, and also effect on RV function. Thank you very much.